Okay, warm welcome to you all again to this session on the investigation and treatment of fungal keratitis. Okay, so in a nutshell, we just described on what is cornea, the different layers of the cornea, right? We talked about something which is known as the keratoplasty. We talked about bullous keratopathy. We talked about the bullous keratopathy. We talked about bacterial keratitis. We talked about fungal keratitis. And in fungal keratitis, we are talking about investigations and diagnosis. Okay, so let's start. So for the investigation, what are we going to use is we are going to use a Sabrow's dextrose agar and this PDA that is known as a potato dextrose agar. Okay, potato dextrose agar. Write with me. Okay, dextrose agar. You know, ophthalmology is one of the most volatile subjects you'll ever see. Okay, like in TU, your ophthalmology, it comes and there's there ENT, there's ophthal, and there's ENT, and there is orthopedics, right? ENT is somewhere it's okay to study. Ophthal, you need too many revisions, and orthopedics is also okay to study. But orthopedics, the anatomy is so difficult to study. I find it in that way. Okay, that was just out of the box topic. Let's come back. Okay, so let's come back now. PDA is potato dextrose agar, and what you can use is you can use KOH for clearing. So 10% KOH, you just remove all the other tissues so that you can just see the hyphae well clear. You can use a microscope and you can just visualize it, right? And what you can use is you can use colchiclor white or you can use Grokut Gourmet. Okay, colchiclor white or Grokut Gourmet can be used. Okay, and whenever you talk about the treatment of choice for fungal keratitis, what are we going to do? For fungal keratitis, what are we going to do? We are actually taking with it natamycin. Okay, natamycin will give as a drug of choice, will give natamycin. And what are we going to do next? We are going to use amphotericin B. And remember that there is something which is known as the intracameral use. Okay, like inside the chamber, cameral drug use. Okay, and in that intracameral drug use, what we can do is we can use voriconazole, and we can use amphotericin B. Okay, and remember, if there is corneal thinning, what are we going to do? We are going to use tetracycline, and doxycycline, as I already told you in previous videos, right? And if there is severe thinning, okay, then what are we going to do? Severe thinning. In case of severe thinning, we are just going to go with therapeutic keratoplasty. Okay, in case of severe thinning, we are going to go with a therapeutic keratoplasty. Now for uveitis, okay, cycloplegics can be used. Okay, cycloplegics can be used. So I hope we are clear till here. Okay, no confusions. Now what you need to remember here is whenever we use drugs like fluconazole, and voriconazole, we always need to monitor LFT. Okay, monitor the LFT. I already told you about cycloplegics, right? I already told you about cycloplegics. Okay, cycloplegics, very important. These cycloplegics can be used in the case of uveitis, like if in case suspected uveitis. So KPs were seen even in fungal keratitis. It was also seen in the case of bacterial keratitis. In the bacterial keratitis, it was perforating. It was pseudo ulcers, right? Perforating and pseudo ulcers. Perforating was caused by pseudomonas, and this pseudo ulcers were because of the excessive amount of cellular debris. It was because of a lot of cellular debris. Okay, and that was also known as pseudocornea, and that is sludging ulcer. Just a recapitulation. Okay, now let's come to a very new fresh topic that we have to talk to, is the um, viral keratitis. Write with me, okay? Please do write. Please do make your notes. Viral keratitis. So in case of viral keratitis, what you need to remember is we have two broad categories, okay? We have two major broad categories. So one is your herpes zoster ophthalmicus, second is your herpes simplex virus, okay? So herpes simplex virus, it can be HSV1 and it can be HSV2, okay? HSV1 and HSV2. HSV2 and HSV1, okay? HSV2, the lesion is below the vest, okay? And HSV1, the lesion is above the vest. But if anyways someone is suffering from ophthalmia neonatorum, in case of ophthalmia neonatorum, HSV2 lesion is effective, okay? HSV2 is the most important, okay? The patient will present with pain. Now you might be thinking like, okay, pain, this pain is very much higher if it is a acanthamoeba keratitis, okay? We'll come to that later. You might be thinking these virus, they tends to go to the nerves, and these nerves are, they go to the nerves, and these nerves are desensitized. We have studied that. You are saying pain may or may not be there, but this doesn't become the like the most important feature that we see, okay? But there might be different other things like redness, photophobia, blepharospasm, okay? Blurring of vision, etc. The major thing that you need to write here is about the signs, and which is very difficult. So I will make a diagram. So in the epithelium, this is your epithelium, then comes your stroma, then comes your endothelium. Of course, this is your descemet membrane is also there. Yep. Of course, there's also the descemet membrane is also there. There's also the basement membrane, okay? Two membranes are also there. So towards here is your Bowman's membrane, and this is your descemet membrane, okay? But what is the most important thing that you need to remember when we talk about viral keratitis? That means it can involve the stroma, number one. It can involve the stroma. It can involve the endothelium. If it involves the endothelium, you know what is the pattern? The pattern is from periphery to central is the pattern, okay? And this is termed as disciform keratitis. Clear? And this is a type 4 hypersensitive reaction. The hypersensitive reaction that occurs in the stroma is the type 3 type of hypersensitive reaction. And disciform keratitis from periphery to central, this is not seen. What do we see actually? We see necrosis, we see infiltration, we see immune-mediated hypersensitivity reaction, immune-mediated hypersensitivity reaction, okay? And in the epithelium, what we can see is, let me just zoom in this part like this, and in the epithelium, what we can see is, what is this? This is superficial punctate keratitis. Superficial punctate keratitis. So I hope this much is clear, okay? Now if you want to go with an investigation, of course you know from your microbiology that we cannot culture, so we can just go for PCR, okay? We can go for clinical diagnosis, okay? Treatment, very important. Treatment. So whenever we go for treatment, the most important thing that you need to remember, when it comes to HSV is if there is glaucoma associated, very, very important. Okay? If there is glaucoma associated, you're never going to give PG analogs. PG analogs. Okay? Never going to give PG analogs. So why are you not going to give PG analogs? Because if you give PG analogs, it promotes the herpes activity. So what are we going to give? Sir, what are we going to give? You're going to give other drugs to control IIP. And what are we going to give to treat the virus? Of course, antivirals. So you can give 0.15% of ganciclovir gel, or you can give trifluridine, acyclovir. Okay, next topic. Herpes zoster ophthalmicus. Very, very important. Okay. So we'll do herpes zoster ophthalmicus in the next video.